Dear friends, thanks to be here. We are going to see how examine a retinal detachment. What is the purpose of this examination? It is to search, just before the operation, all the clinical details that will allow to adapt the best strategy. And what is the best strategy? Well, as for all the functional surgeries, it is to exert the minimum and sufficient trauma to allow anatomical healing with the least possible complications and the greatest functional recovery. All the challenge is there. Of course, in front of a complete detachment with a small tear at 12 o'clock, we can do a vitrectomy and the 360 backing. We will certainly have little risk of recurrence on this eye, but we will had the complications of vitrectomy with the risk of macular edema linked to the verticus compression by the backing. With a small buckle from 11:30 to 12:30, there will be no vitreoretinal carceration, no macular edema, and the recovery will be 100% of what it was previously before the detachment. But to decide to do only that, you must be sure that the examination has not missed anything and that everything had been identified. This is why this examination is so crucial and have two goals. First, to identify all the retinal dehiscences, from the largest one to the smallest ones of 30 or 50 microns, noting their hourly situation with possible landmarks and their situation according to the vitreous base. But also to identify all these signs which make it possible to understand the pathogenesis and the level of evolution of the detachment. Is the hyaloid detached? Are there signs of retinogenic detachments? What is the level of pigmentary turbidity? Is there a circumferential retinal fold? How are the vitreous traction? Are they active or relaxed? How are the connecting lines between the detached retina and the flat retina? Are there fixed fold? What is roughly the volume of subretinal fluid that I will be able to drain? Where will I perform the drainage? In short, all these signs that will make up some time for cryogas, for buckling, or for vitrectomy with or without buckling. This must be known before starting the operation program, because it will allow to know more or less 10%. How long will it take for the procedure? Nothing is more tiring than to change strategy during operation if one have, for example, not foreseen that there were not enough space to inject a gas bubble. You may have to do an unscheduled vitrectomy, which will cause an additional installation, a vast of time that you will try to recover, and above all, a feeling of disorder, which will be energy consuming. So you have to plan ahead for anything that might happen. So I know that there are some places where the operator does not examine the patient before operation. The patient is seen by the resident on duty who places the indication for systematic vitrectomy, and the surgeon discovers everything during the vitrectomy. I think that this is a mistake. Admittedly, this examination takes time to be properly conducted, but the information it provides, even if a vitrectomy is decided, is so useful in establishing its own strategy And even the location of the trocar, if the resident didn't see that there were choroidal detachment. So it is so useful that it must be done. For me, an operator who does not examine the patient before the procedure is a loss of chance for the patient, and moreover, the EVRSRD study is proof of the need of this examination. Well, you ask your patient all the usual questions about functional sight and their age. Intraocular pressure was taken, as well as visual acuity. The patient has been dilated and is sitting here in front of you. The first thing you will notice is the quality of the pupil dilatation. A good dilatation is a very good prognosis. You will take this opportunity to defocus a little bit in the vitreous, because when the PVD is complete, you can see the posterior haloid and the vitreous moving during the movements of the eye. I then used to systematically examine the posterior pole with a simple Volk lens without contact to watch at the macula. Not so much to see if it was detached, because it never really influenced my strategy, but especially to see if a retraction syndrome could direct me forward vitrectomy. I was also afraid that at the end of the examination, all absorbed by the examination of the periphery, I would forget to look at the macula. I took advantage of this lamp to make a small retroequatorial tour and establish the route limits of the detachment that I noted on my drawing before placing my contact lens and watch the periphery. And here we come to the first discussion. I should even say confrontation between the defenders of a biomicroscope slit lamp examination, mainly French or Japanese, and the defender of the indirect ophthalmoscopy. You know that I'm not a politically correct guy, so I will tell you really what I think. It is true that Charles Kepens was a brilliant surgeon in moving doctors from direct ophthalmoscopy to indirect ophthalmoscopy and making them discover a wider world. I can testify because I knew the time when direct ophthalmoscopy was used to examine and operate on a detachment. I'm not talking about the quality of the clinical finding analysis that could be done. But in doing so, Charles Kepens also established in all the Anglo-Saxon countries and in all the countries which imitate them a certain archaism by keeping the operators away from the biomicroscope, because the biomicroscope has two fundamental advantages. First, thanks to the optical cut of the slit lamp, it makes it possible to analyze the vitreous, to appreciate the relations between the vitreous and the retina, to judge the activity of a vitreous traction, and therefore to set a strategy very precisely adapted to the precise evolution of the vitreoretinal disease, because it is a vitreoretinal disease, not only a retinal disease. Which surgeon of the anterior segment could do without the optical cut? But in addition, the biomicroscope, thanks to the magnification, will also make it possible to detect holes of 50 microns, invisible to indirect ophthalmoscopy or to the wide field lens. Furthermore, the indirect ophthalmoscope, because it uses a non-contact lens, does not allow the continuous examination of the periphery to be carried out millimeters after millimeters. It forces you to make jumps that make it possible to forget a tear. The biomicroscope, therefore, authorizes the operator to treat only by indentation what he has detected, because he knows that there is no other dehiscence. He is therefore not obliged to do a secure 360-degree backlink to protect himself from having forgotten something. All of this goes in the direction of a more limited and therefore minimally invasive surgery. This is why I will limit the benefit of the indirect ophthalmoscopy to examining a small child or a disabled person who cannot be examined by a microscope. Which lens to choose? Free mirror lens, Underscope, spheric lens, non-contact lens. In fact, each lens has its qualities and indication. Let's start with a phakic subject with a nice pupil dilatation. In fact, with the patient we saw earlier. For the preoperative exam, I will use the free mirror lens. I would also have chosen it for an aphakic subject with a good dilatation. I'm going to start at the level of connection between the detached and the attached retina, focusing on recognizing whether the detached retina approaches the pars plana with an acute angle, sometimes even asymptotic one, or on the contrary, with a right angle, even obtuse. Then I examine the detached retina and especially look at these small white details highlighted by the optical axis of the slit lamp. In case of doubt, I got to magnification 45 and I write on my drawing all the information, either the open tears or the areas to be checked with cryo. You see that here all the tears are on the vitreous base, which appears as a small white line. Each millimeter of retina is examined continuously without making a jump. Nothing can therefore be missed because everything is checked and listed at high magnification. I counted 5 tears and 2 suspicious areas to be checked intraoperatively. Now let's go on the Underscope, marketed in the past by Rodenstock, and which is, I think, more difficult to find today. It is a rather bulky and heavy lens, and which certainly gives, in phakic eyes, a less good visibility of the peripheral retina than a Goldman lens, but which allows to correct examination in case where the iridocrystalline plane reduces access to the free mirror lens. It is therefore recommended in case of miosis or in a pseudophakic eye having had a YAG capsulotomy for PCO. Let's see what happened in the same phakic patient. Immediately we see that we have this beautiful overall appreciation provided by wide field lenses. We immediately see that the connection zone goes back up to 9–10 o'clock. And we can see the vitreous base. But the tears are identified with less security because they are located at the limit of the exploration field of the lens. It would be hard to identify so exactly the 5 tears seen earlier. On the other hand, we always benefit from the progressive examination millimeter by millimeter. Now let's go to the quadraspheric lens, always in the same patient. And there you see it is a marvel to see the vitreous, to see, like here, the posterior haloid intact and detached. The quality of the image on the central retina is magnificent. But on the other hand, as soon as we approach the periphery, a gray area prevents us from seeing the details seen with the Underscope and a fortiori with the free mirror lens. This lens, in my opinion, has an interest for making beautiful videos and for examining the vitreous. Let's finish with a non-contact lens from Volk. The vision of the posterior pole and the vitreous is not bad. Not as good as the quadraspheric lens, but not bad at all. We can, by asking the patient to look in the desired direction, have access to the periphery. A little bit like with the Underscope, or even a little more peripheral. But the absence of contact, fixing the globe, and the fact that the patient is going to move prevents this impression of continuous examination, millimeter after millimeter, which gives the assurance of having seen everything. I will therefore reserve this lens for cases where one does not want or cannot have contact with the patient's eye, that is to say, essentially, for the immediate post-op. On the other hand, we can use this absence of contact with the eye to judge, in case of doubt, the vitreous attachment of the retina by dynamic maneuvers, asking the patient to move the eye. So, to sum up, each time you have wide access to the posterior pole, phakic or aphakic, with good dilatation, or pseudophakic without PCO, use the quadraspheric lens to see the vitreous, but choose the free mirror lens to detect all the small retinal details. When access to the posterior pole is limited, then you will use a Underscope. It is normal to give preference to Goldman lens when possible, as it will give you the highest magnification and the least optical distortion. So I know that it disturbs some users of the indirect ophthalmoscopy who ask me questions like, Didier, what do you see on the left? It is left or right? And invariably I was answering them, do you ask yourself this question when you shave in front of your mirror in the morning? Would you prefer to shave in front of a wide field lens like a witch's mirror? Of course not. You prefer to have the best image without wondering if the hair you see in the mirror is up or down. But let's go back to the examination. You will therefore go around all the detached and non-detached retina, because you can find a tear in a flat retina that will have to be treated. You will note all these clinical details that we saw in chapter 2. Signs suggesting a retinogenic detachment, vitreous turbidity, circumferential retinal fold, intensity of vitreous tractions, sign of PVR, lattice degeneration, areas of atrophy or photocoagulation that may hinder the progression of the detachment, all those details that can influence the strategy. Then you will consider your drawing before deciding what to do, to see if everything is consistent, according to the Linkoff laws. This is an important step that can allow you to discover the missing tear, that is to say, the tear that you have not detected. Let's take a closer look and consider the hypothesis that no chorioretinal adhesion interfere with the extension of the detachment. I just have a small two or three things to add to the Linkoff recommendation. Let's first see for a superior detachment on a right eye. If the tear is exactly at noon, since the papilla is offset nasally, the detachment must descend slightly more temporally than in nasal. For the two extensions to be symmetrical, the tear must be at 12:30. However, if it is at 1 o'clock or 1:30, the detachment will be asymmetrical, of course. In temporal, detachment of this style will be caused by a tear at 11 or 11:30. Now let's see the lateral or inferior detachment, still on the right eye. If the detachment has an asymptotic connection line to the pars plana, this means that the tear at the origin of the detachment is located within 1 hour or 1 hour 30 below the highest connection point, and that the liquid passing through the tear detaches the retina under the effect of the gravity. What does this imply in practice? If you only detected a tear at 7 o'clock, this will not be consistent. This tear would have been created secondarily during the creation of the PVD, but it is not the initial tear, and it will be necessary to return to this area of 10 o'clock to look for the missing tear. If, on the contrary, the connecting lines are at right angle to the pars plana, or even if they go back, this means that the liquid which passes through the tear pushes the retina in all directions. The responsible tear is therefore in the central part and cannot be within adjacent to the connection area. Well, you have noted all the clinical details and your drawing is consistent with everything we have seen. You can therefore tell the story of this detachment. It is a detachment of the phakic, stage A. I saw 2 small tears, and I'm sure that there are no others. The first, on the posterior edge of this lattice at 1 o'clock, is at the origin of the detachment. It has a very tight vitreous traction which will have to be released. The second at 4:30 occurred secondarily, and the very relaxed aspect of the traction shows that it may not be mandatory to relax it, especially since there is no circumferential fold and that the posterior haloid seems to be detached all around. I have an amount of subretinal fluid of about 1 cc and a half. I will therefore have no difficulty to perform nearly a quadrant buckle supporting the first tear and the lattice, which will take me 0.3 cc's of pace, to drain at 3 o'clock and to inject 1 cc of gas, positioning the patient on his right cheek to tamponade the second tear and avoid indenting an hemiretina. It will take me 20 minutes. I schedule the patient for tomorrow afternoon. This is how you can speak about your cases. So you have your strategy written down, release the first tear quite clearly, and perform a gas subretinal fluid exchange to buffer both the first and the second tear. So you are going to use multiple weapons: cryo, indentation, drainage, and gas injection. So you need to know the role you can expect from these different weapons before knowing how to achieve them. This is what we will see in the next chapter.